is Eyes on Dry Eye 2025. I hope everybody's enjoying themselves. A lot going on in the clinical track, exhibit hall. Check out the sponsor booths, a lot of cool things to download and engage with our reps that are there to help you out. This is going to be a new feature at Eyes on Dry Eye, and I'm in the hot seat. Well, what does that mean? All things dry eye disease, fair game. I'm going to take your questions. I'm going to be monitoring the chat. Eyes on team is going to be sending me stuff that they had in different pre-event surveys. I will make comment on things that I've seen throughout the event, but how this goes is going to really be dependent on our attendees. So I want you to engage. Full disclosure, I am a consultant for a lot of the companies in the ocular surface space. I will be giving you my opinion. I will be telling you when something is, I believe, evidence-based, or I'm not sure, or strictly opinion, and we'll see where this goes. So I'm officially in the hot seat for the first time ever at Eyes on Dry Eye, and let's start the questions. All right. So Jen asks, I'm not seeing the same results that I would expect with IPL, okay? I have patients that aren't always getting symptomatic relief after 5 sessions. Their meibography doesn't look any better. What am I doing wrong? Other practitioners rave about IPL, but I'm becoming hesitant to recommend since I'm not seeing major improvements. Big topic, good questions, Jen. And let's run with this. So when I look at somebody that I'm recommending IPL, and I've had IPL in my practice since 2019, we have luminous technology. We have an M22 in one location and an Optilite in another. This is somebody that the primary reason we're going to use IPL is to treat inflammation generally related to meibomian gland dysfunction. So just because I buy an IPL and use that on a patient is not a silver bullet. It does a lot of things, but it doesn't do everything. So I want to make sure that when I'm assessing this patient, I understand what's going on. Yes, they very commonly have dry eye and they have inflammation on the surface of the eye and in the eyelids, but they could also have meibomian gland obstruction. They could also have biofilms, Demodex, they could have poor tear production. IPL isn't really going to do all that great of a job on the biofilm that's on the lid margin. It's going to kill bacteria and Demodex around the eyelids, but not obviously on the lid margin where we're not going to be able to treat with IPL. It's not going to do a great job of removing meibomian gland obstruction. It just doesn't get hot enough to be able to do an expression there. So there are other tools that I will use for expression. If someone's severely aqueous deficient, I certainly am going to consider immunomodulators, nasal sprays, lacrimal occlusion. So then we get back to what is it that we're treating? We're treating eyelid inflammation, and I'm going to position that for my patient. This is what this does. Saying that, if the predominant issue with this patient is dry eye due to MGD, eyelid inflammation, and another telltale sign there certainly will be looking for those lid telangiectasias on the lid margin or any sort of facial rosacea. They don't have to have facial rosacea. Almost everybody that you're going to be treating those is going to have some lid margin telangiectasia. So I know that if I identify this is what this does, and if we do 4 sessions, typically if it is the correct patient type, 80 to 90% of people are going to have symptomatic improvement. I let patients know that there is no cure for dry eye, and that if they get the improvement that I expect with IPL, that they're going to need to do at least a single maintenance session every 6 to 12 months to see that continued improvement. So this, why isn't this not working? Let's make sure there's not other things that we have to treat beyond inflammation, lid margin inflammation that could be, throwing a wrench in your treatment plan for this patient. If I do not address their meibomian gland obstruction, IPL is not all that great of a tool for that. I'm going to use in my clinic tear care or LipiFlow or low-level light to help with a heated expression. It's not going to help with DB. It's going to help, again, the Demodex around the lids. But if they have DB, I'm going to need to treat that with lotilaner. And it's not going to help someone with tear deficiency, at least predictably. So what am I missing? Is make sure we're not overlooking the other things that could be contributing to this patient's presentation. Saying that, IPL is probably one of the most powerful tools that I have. I use it every day when I'm in our ocular surface disease clinic. It's one of those things that I don't feel like I could live without. And I think that that will continue to be my treatment algorithm for some time. I don't really expect to see improvement predictably on mybography, although there are some reports of improvement. I'm generally not looking for that. That's not what's driving my decision-making. I am seeing improvements in their MMP9, in the lid margin telangiectasia or erythema, in the meibomian gland secretions, and very often in patient symptoms. So great question from Jen. Next question. IPL versus RF, opinions about them, recommended equipment, fee structures, success and failures, pearls. I'm not sure who threw that one in there, but a lot of things going on with that question. So IPL versus RF. IPL, anti-inflammatory, has some photobiomodulation effects. It can thin the secretions and it can help with symptoms. It does not do a great job of helping with meibomian gland expression. So you need some sort of heated technology, and RF is going to be one of those ways to do that. So that's going to be heat that's generated by electric current that is also going to tighten the skin, improve circulation, and liquefy some of those secretions to help you with expression. I don't have very much personal experience with RF. I've demoed a couple units. In my clinic, I've felt like we've had good to great results with some of the technologies that are on label for treating meibomian gland obstruction with tear care, LipiFlow, iLux squared. For things that are not specifically indicated for meibomian gland obstruction, like RF or low-level light therapy, clearly they're useful. I think more studies are needed. I think the most compelling study is looking at what we had said earlier. Somebody has inflammation and obstruction, real good study in 2023, looking at IPL plus RF plus MGX, or meibomian gland expression. And in those patients that had the inflammatory treatment with the IPL, the heat treatment to remove the blocked obstructions, and then manual expression, that was helpful in both signs and symptoms of dry eye. So IPL versus RF, that's not how I look at it. It's apples to oranges. It's IPL plus RF, or IPL plus some other technology that is going to be adequate to give you a good heated expression of the meibomian gland. Recommended equipment, I would say that I can only speak to my experience, and that's with Luminous technology. I think there are other reputable companies in this space that are out there that can supply devices for both IPL and RF. I think that regarding, in particular, IPL, Luminous has done a lot of the legwork of studies to get that FDA approval for dry eye secondary to MGD. IPL with Luminous technology improve signs of the dry eye in those patients. So I think that we're not comparing the two, they're different animals. Fee structures, boy, in this setting, I could get myself in trouble. It is the hot seat. When I start talking about money and fees, I get a little sweaty. I think that you have to do what's the right thing for your patient. In my practice, in an ODMD practice here in the Midwest, I try to price these so that they're as affordable for patients as possible. I want to have lots of patients being treated. So we're not trying to gouge anybody. We're trying to do something that's a fair representation of the time that it takes for myself and my staff, as well as the technology to treat these patients. So I would say do not sell yourself short on that, nor should you try to do something that's simply about trying to make the greatest amount of money possible on every patient. Success and failures, like anything with IPL, you get better as you do more of that. You get better with the patient conversation. You get better with understanding who is a great candidate, who's not so great of a candidate, and being able to understand which of these patients potentially may need something more than just IPL or RF to be able to treat their problem. So pearls, I think that highly recommend IPL and some form of thermal expression. We've talked about the different ways that you can do that. I think that most patients are going to need both inflammatory therapy and obstruction removal while paying attention to the biofilms on the lid and not forgetting those. In my general clinic practice, we have low-level light, we have tear care and LipiFlow, and we have IPL. In patients that have mild to moderate inflammation, mild to moderate obstruction, I can often get by with just using low-level light only, 3 sessions spaced out by a week or so with manual expression after each session. In patients that have greater degrees of obstruction, I need a greater thermal treatment for those patients. That's where I'll look at these other technologies. And then certainly anybody beyond mild inflammation on the ocular surface, especially with lid telangiectasia, symptomatic patients, that's where IPL fits in. A go-to lately really has been IPL 4 sessions, followed by immediate sequential low-level light for 15 minutes with the mask-based system, Equinox, and then manual gland expression. And then at a minimum, a nutritional supplement, some lid hygiene at home, and then looking at, do I need to add medication to that patient to maintain that? So a lot of different ways, a lot of questions within the question there. I appreciate that. All right, let's move on. And I'm monitoring the chat to make sure that there isn't anything else that I'm overlooking here. So far, so good. Keep the questions coming, though. Eyes on, bring it on. If the patient had incisional glaucoma surgery, would any of the prescription medications that are approved for dry eye not be recommended? So incisional glaucoma surgery, if I think about all of our options for prescription dry eye medication in the United States, I would certainly be careful about using a topical steroid without carefully monitoring their IOP. And then in terms of treatments that I would do that are more advanced, cryopreserved amniotic membrane, with Procara in my practice, I'm going to avoid that in someone that's had a tube or a trab. So those are the things that I would not do. Really, every lid treatment that we would do in the office would be on the table. Treatment for Demodex blepharitis is on the table. All right. With all the cyclosporin treatment options, what thought process goes into a selection? Of course, insurance is part of it, but just on product itself. Okay. Well, I'm really in the hot seat on this one, but that's why we're here. So if we look at cyclosporin in the US market, we've had that available for more than 20 years. And when I think about any medication, I'm going to be thinking about when I recommend that for a patient, I want to look at the efficacy, patient tolerability, and access. And depending on the patient, it may not be exactly in that order. Maybe access is most important, maybe tolerability is most important, maybe efficacy is. So if we limit our discussion to Restasis, Cequa, and VEVYE, Restasis we've had available for over 20 years. It's an ophthalmic emulsion, 0.05% cyclosporin. It has the refresh Endura vehicle that allows the cyclosporin to penetrate the ocular surface and was the first medication approved for dry eye disease. It is the biggest blockbuster success in dry eye in terms of the duration that's been on the market, the number of prescriptions that have been written, and still lots and lots of patients are on branded Restasis. But it is a emulsion, and it is something that now there is generic available for the 0.05% ophthalmic emulsion. So enter into the market Cequa, and this was roughly 5 or 6 years ago. I would say that Sequa 0.09% solution. Now, the innovation there is nanomicellar technology to get the cyclosporin, more of that, into the target tissue. What did that mean in terms of clinical studies? We saw earlier improvements in corneal staining, improvements in tear production at 3 months, and even some improvements in visual acuity a couple months after therapy. So I think that Sequa continues to be my go-to. And when we look at what's compelling Sequa versus Restasis, we actually have that data in a switch study looking at patients that were not Restasis failures, but had been Restasis for on average over 3 years. And these patients were not totally satisfied in terms of their symptomatic relief, or they still had corneal staining, as they had an incomplete response to Restasis. So a phase 4 study looked at that, where these patients were switched to Sequa. And it found that patients, after using this for several months, had improvements in corneal staining. They used their artificial tears a lot less. And the majority of patients said, yeah, I prefer to use Sequa versus Restasis. So that is a conversation that I can have with my patients that I feel have had some response to cyclosporin. They're not a failure, but it's not doing everything they needed to do. So Sequa, been around for 5 or 6 years. Enter VEVI. We just had a great presentation here on everything that Hero is doing. This is going to be the first semi-fluorinated alkane that has 0.1% cyclosporin. When you use that semi-fluorinated alkane, we no longer need to have an aqueous or water-based trough, so it's a much smaller medication. I think the early results on that have been good. I think patients, it is well tolerated. There are some patients that you put them on an aqueous-based drop and they just can't tolerate it, burning and stinging. We see less of that with the introduction of VEVI into the U.S. market. I think that there are patients that you really can't predict how they're going to have side effects when you look at whether it's Xiidra or Sequa, VEVI, Restasis. These are sometimes really impossible to understand which patients are going to have which side effects. The VEVI label is different. It's indicated for signs and symptoms. That's the first cyclosporin to have that in the U.S. And the semi-fluorinated alkane does appear to improve penetration of the ocular surface. So I think downsides to it would be simply getting a patient to understand that it's a very small drop. And early on, I had patients that were going through the bottle pretty quickly. I think that was poor education on my part. Now that is not as much of an issue. So loaded question there. I appreciate it. And I just really am glad that we have so much innovation. Looking at the chat, Martin, longtime viewer, mutton fat meibum. All right, tough case. I want to see, Martin, what you're doing for mutton fat meibum now, just for reference. So if you can put that into the chat. The patients with mutton fat meibum, this thick, pasty meibum that you treat and it's not getting better, I think you have to do kind of a full court press for these patients. Look at what they're putting into their bodies. If there's a lot of processed foods, you're going to want to educate them about that. You're going to want to get them on a good nutritional supplement. Some of these patients will also do well with a course of doxycycline or azithromycin to be able to help with the posterior blepharitis part of their condition. These are patients that I'm very commonly going to be using IPL for, IPL in combination with a thermal treatment. They may need more than your normal 4 sessions, what we're using with our Luminous technology. They may need 5, 6, 7 sessions initially. I'll let the patients know that. I'm expressing every time after I do a thermal treatment so I can see the quality of that meibum. I think almost universally these patients are going to need to be on a topical immunomodulator. In my experience, I would be choosing Sequa and Xiidra as my most likely scenario there. And then I think that we've learned today, big topic of discussion has been Demodex blepharitis. Boy, if they have Demodex blepharitis, any hint of that, I'm going to treat that with Xdemvy, because I know if I don't do that, is going to make it less likely I'm going to get the outcome that I want. So I think all of those things can improve the situation, but there is no silver bullet, as you know, Martin, for this mutton fat myebum. I'm looking here at what she says, MD fungal infection. I've not done that. Gut health for sure. Epstein protocol with more aggressive IPL. Agree. We're pretty well aligned. I think that, lucky to have Extembi for sure. I think it's not the missing component, but a missing component is don't overlook DB in these patients that have hard to treat MGD. And in fact, we said it, in my conversation with Priya, is they have that. I'm actually going to treat that before I even start the other things, because if I wipe out the Demodex, that's an easy win. And then I can understand how much of the other things are probably not related to Demodex. And I've got a better plan for my patient. So thank you, Martin, for the question. And I appreciate everything that you've done and interacting over the years at Eyes on Dry Eye. Looking at our next question from the Eyes on team, a patient has a rapid tear breakup time of 2 seconds. What is the most likely cause? All right. This is some of the things that I get as a text message, or you get a photo or OCT from a colleague. It's, hey, what's this? What should I do? Is I need a lot more information than that. So what are the best treatments for rapid tear breakup time? So we think about tear breakup time, we're talking, well, that must be evaporative dry eye. And studies, looking at devices and MGD and evaporative dry, they look at tear breakup time. But if someone's aqueous deficient, they're going to have a reduced tear breakup time as well. So I don't think that in isolation, if someone said my tear breakup time is 2 or 3 or 6, I don't have enough information to understand why that is. So this is a really good question in the fact that there isn't one diagnostic test that tells us everything. In my clinic, we do a speed questionnaire for symptoms. I do a history. I'm looking at their ocular comorbidities, their systemic comorbidities, their history of surgery, their medications, understanding what are all the things that would be contributing to dry eye disease. I look at their tear meniscus height. If that is low, that's telling me that they are likely aqueous deficient. I look at whether or not they have clinically significant MGD by doing a Corb MGE evaluation in every patient. I'm looking at osmolarity. I'm often looking at MMP9. And then I have a new instrument called the BOSA, which is from Bruder, that gives me non-invasive tear breakup time, tear meniscus height, lipid layer thickness. I can do mammography. So it sounds like a lot, but when you have that process in place and you screen for symptoms, you have a trigger to do point of care diagnostic testing, you have a device that gives you as much information as you can, well, then I have a lot of information before I even see the patient to understand what I need to do. So I'll ask some patients some confirmation questions. I'll make sure we're screening for autoimmune disease, fluorescein in the eye, look down, look up. I like lissamine green as well. I take all of that in addition to their rapid tear breakup time, try to figure out what their diagnosis is, make sure it's only dry and there's not other issues too, and then come up with an appropriate treatment plan. The other thing that I think about when I hear tear breakup time is what Donald Korb told me one time is tear breakup time is fickle. It is difficult sometimes to see predictable improvements depending on the therapy that you're using. So tear breakup time, I think, is an important diagnostic. It's not terribly specific. You can look at mucin deficiencies in some of these patients with abnormal tear breakup time. Long-winded answer is I need more information than 2 seconds tear breakup time to tell you what to do for that patient. Checking the chat. All right, a few more minutes here. And we have another big one here. All right. Can you give any advice on getting prescription dry eye medications to our patients at lower costs? All right, we saw a lot of that in the chat today. I'm going to do my best. That is a very challenging question. I would say this is a question that all of our supporters and industry folks are trying to help us with. So at a minimum, you need to understand the programs that are in place, that are existing, that these companies are investing a lot of time and money to make that happen. Manufacturer coupons, the use of specialty pharmacies. But in our practice, with 20 doctors in 7 locations. We looked at this and really dug in a year ago and said, let's figure out an algorithm internally to take the pressure off of our teams to be able to do what we want to do to treat our patients as efficiently as possible. So that means understanding for a Medicare population, a commercially insured patient, as well as an Indiana Medicaid population, like where should we send a prescription? What is the process? And what we settled on was we have a single way to do it for every bucket. If somebody is getting prescribed, for instance, VEVI, and they have Medicare, there is a specific way that we're going to do that utilizing a specialty pharmacy. If someone is prescribed Xydra and they have commercial insurance, well, I've got a path that I'm going to do that's going to take some of the burden off of my team. And what we try to do is make that universal across the practice, and we're utilizing specialty pharmacies as much as possible. I don't hand out manufacturer coupons for these things. I really try to avoid sending patients for a branded medication, whether it's dry eye or glaucoma, to a retail pharmacy, because I just don't know what's going to happen to them. I want them to have the best experience possible. Lean on your sales reps to help you. There's even things that they have in place to escalate that if you're having trouble getting a patient the price they deserve. Saying that, not everyone is going to get the medication that you want at an affordable price. But if you don't understand the rules of the game, I don't think you have any shot. Or if you have a practice that this doctor's doing it this way, this doctor's doing it this way, good luck. We've tried that. It doesn't work. You have to commit to a way to do this and utilize the things that are out there. That is one element of that. I'm looking at the chat to make sure before I get into the other piece. The other element is just make sure that you're documenting appropriate. You know, if you need a prior authorization, dry eye is a symptomatic disease. Make sure that you're recording their symptoms in your patient chart, and make sure that you're recording what they've done in the past. Have they used artificial tears? Have they been on a particular immunomodulator? Have they failed some sort of therapy? Because that is going to help you get access to some of these medications. If they have dry eye in my clinic, they are symptomatic patients that have loss of homeostasis. How do I document that? Why their osmolarity is high, or they have a rapid tear breakup time, or they have significant ocular surface staining. Any one of those things plus symptoms is going to get a case-SICA diagnosis in the majority of cases. And all of those things are going to be important to PA proof of my chart to make it more likely that when we need to provide information to get a medication covered, that we can make that happen for our patients. So the hot seat was pretty darn hot tonight. We will get another crack at it tomorrow. And I really appreciate Martin and others chiming in. And Zoculash serum, I've not used that, Martin. I do use ochre-based products with ZocuShield, ZocuWipe, and then doing Zest procedure in my practice, also doing Nuliz Plus in my practice, or Nuliz Pro rather. And I think that treating the biofilm is going to be something that we're not going to want to overlook. I am going to take myself off the hot seat. I appreciate the questions. We'll have another crack at it tomorrow, and I hope you enjoy the rest of the show.